behavior reduce the spread of HIV. That's why the epidemic is in Asia is kind of like different in Africa compared to Africa. And the picture of HIV epidemic in Asia is very diverse, and epidemic in Indonesia and Vietnam still growing, but prevalence in Thailand, Cambodia, and Myanmar show declining due to effective prevention. So that's what we learned from the Asian country from yesterday presentation. And now we will begin the session. So it's the sixth session, and I will invite Dr. Subas. The time is yours.
Oh, okay. Good morning again to all the campuses and the satellites. I was trying to recapitulate after the moderator has just recapitulated and summarized what we discussed last time, looking at where the epidemic status is in the global situation and how the Asian numbers haven't declined much, and so have the new occurrence or occurrence of new infections globally at 2.5 million infections every year. Today we will discuss about risk behaviors and the risk behaviors which would make individuals vulnerable not only to STIs and HIV infection, but also the other health damaging behaviors, which include for example, the individuals who take risky behaviors in terms of sexual transmission of HIV also are 5 or 6 times more vulnerable to use of drugs and intravenous drug use, and also similarly very high potential for other health damaging risk behaviors. So having known that, let's go a little bit back again, or restart again back from where the epidemic began 27 years ago. I'm sure that we did talk about year 1981, where the investigative research, something that is now beginning in terms of swine flu, that is, I'm sure all of you in the schools of public health are watching this flu that has begun from Mexico. And similarly, this investigation began in 1981, where 2 young men in New York and 3 young men in San Francisco, they developed pneumocystis carinii pneumonia, some infection of the lungs caused by pneumocystis carinii, a pathogen, which normally does not happen in young people, but these were young men, 5 of them, and it signaled the occurrence of some form of immune suppression. So the U.S. Public Health Agency, the Centers for Disease Control, sent out young trainees who are in the medical intelligence system to go to New York and San Francisco, and all the PCP patients, they were found to be men having sex with men. They are predominantly between 22 to 30 years old, 5 people. And they came back in the first report in 1981 with a conclusion that the immune suppression happened in these young men in the U.S. due to anal sex. And when there is anal sex, there's likelihood of a lot of blood vessels breaking in the recipient as well as the insertion. And if the semen leaks into the bloodstream, it is immunosuppressive. So that was the first conclusion of the report, and more or less was pretty convincing. But there were people who thought that why only these 5 men and why it's happening now? And so they said, well, have we completed investigation enough? And the answer was no, because they finished all this in 60 days. So they said, okay, let's send another team, a team that is not gone up earlier, because you want to reinvestigate these 5 deaths. And that again talks about public health, to be investigative, to be suspicious, to be having more questions all the time. So the second team went again back to San Francisco, New York, and they studied the sexual trees of these 5 individuals. And they found that all 5 of them were somewhere linked up in their sexual trees. And obviously the sexual trees of MSM are very, very complex, because they tend to have more turnover of sexual partners every month. So with those extreme complex sexual trees, a new conclusion emerged, and they said that somewhere these 5 men, although they are living separately, wide apart in New York and California, but they have been meeting each other sexually over a period of time, and so a new entity was then labeled as AIDS, and it was labeled predominantly as gay disease in the U.S. in 1981, saying that it was predominantly the sexual characteristic. The risk behavior was excessive number or change of sexual partners and having sex through the anal route. So with that came, in 1982, an observational research started in Africa, in Lusaka, Zambia, where 3 young men and 2 women, they were presented at the hospital with severe weight loss, pulmonary tuberculosis, diarrhea, herpes zoster. So those were, again, the clinical features of suppression of immune system in these individuals. And because of the pulmonary TB, they were on the standard anti-TB treatment, and yet they died within 6 months while they were on anti-TB treatment. And this was then written up as a publication in the medical journal, and left with a conclusion that the possible causes of AIDS occurring both in men and women in Africa possibly suggests a causative agent, and raising a theory that is probably not a gay disease in Africa, but it's probably something that is happening in men and women, and possible heterosexual transmission of a causative agent that was not known in 1983. And for some of the schools of public health who are not physicians, we talk about AIDS, but several people in the schools of public health do not seem to have a face of AIDS attached to their memories. And when we talk about severe weight loss, these are the areas where the weight loss is looked at, not at the abdomen, because the abdomen in this individual is bloated up because of the tuberculosis there. But essentially, these are between the ribs where most of this weight is lost. Look at the arms of this individual. How do I go back? From here. Yeah, thanks. And the various types of infections on the face, and you can see the loss of the fat on the cheeks. So it's important to know the disease, but at the same time also important to know the images of the disease. And these can be very frustrating chronic diseases that occur in individuals with AIDS. It's not something that is like swine flu, for example, where the suffering is only for a few days and then goes into the lung disease and death. While this goes on with an average period of, with a natural history of about 8 years of survival. So the simultaneous investigation started in 1983, and here were the men having sex with men groups. And these were in New York, these were in San Francisco, and Miami. So you had 3 multi-center studies going simultaneously. And what they found was that the percentage of HIV in gay men in New York, San Francisco, and Miami was linked with the number of sexual partners. So those individuals who had less than number of 10 sexual partners were likely to, were found to have like 2 to 4% of seroprevalence for the infection, as compared to those who had 10 to 50 sexual partners, as compared to those individuals who had more than 50 sexual partners in the last 1 year. So the risk characteristic identified in MSM group were two. One was, in the study here, it was that the number of sexual partners is directly proportional with the likelihood of these individuals being infected with the virus that causes AIDS, because that the name was still lingering with HTLV3 and later became HIV as a virus. So with that characteristic, the studies moved on, and Africa became the focal point for lots of early studies. The reason being that the levels of infection in Africa was much higher than the gay men in New York and in San Francisco. And this is a study that was done in Lusaka and in Nairobi, where the individuals with genital discharge, these are STIs, tend to have HIV prevalence between 4 and 11%, as compared to those individuals who had genital ulcer disease, as compared to individuals who had no STI but were pregnant. And you could probably again correlate from these findings of these studies, talking about, again saying that the cofactor story of individual having ulcerative sexually transmitted diseases already are more prone to transmit or receive HIV infection. So there was a correlation again in this study. Then there was that if sexual transmission is related with high number of sex partners, then we would possibly find sex workers having a higher prevalence as compared to pregnant women in the general community. So you go to the antenatal clinic and you look at what is happening in Nairobi, what's happening in Amsterdam, and what's happening in New York with women attending the antenatal clinics, considering that most of these women are housewives and are not sex workers. At the same time, then you go look at the sex workers, which are brothel-based sex workers in different parts of the world across the continent. And again, this was showing the distinct difference between women who were sex workers versus women who were not sex workers. And you find that there is a correlation with the number of sex partners and the acquisition of HIV. And then there was an epidemiologic study done to look at transmission of the virus HIV by then through mosquitoes, that if there is so much of HIV prevalence in communities and mosquitoes are transmitting the malaria parasite, what would prevent the mosquitoes not carry the virus after the bite from one person and take it to the other person? And this study then was designed in a community which is northern part of Zambia, absolutely next to Zaire that I showed you during the last lecture. And the community prevalence of HIV at that time was already 10%. And it was hyperendemic for the whole year for malaria cases. So the hypothesis in this case was that if the mosquito is transmitting the HIV, then it will not only transmit between adults or transmit to the adults and leave the children without the virus. So let us go to the children who are non-sexual active, who are not sexually active, 6 to 12 years in school-going children, and look at the level of HIV amongst those children. Now, if the mosquito is the transmitter, then obviously the mosquito will be biting the children as well. And out of the 4,400 school children, only one 11-year-old girl was found to be HIV positive, and the history later suggested that possibly it was an early sexual transmission exposure. So this laid to rest an epidemiologic paradigm or an epidemiologic dilemma that the mosquito was not going to be a vector important in the transmission of this virus. So within the transmission characteristics, this was a major kind of issue resolved. And then came the era of how do we modify the risk characteristics of this epidemic. And that is what we call as interventions. We want to modify the risk behaviors, we want to modify the cofactors, we would like to modify as many areas as possible to try and slow down the HIV epidemic. So one intervention that was started off in Tanzania in a large community where there was a lot of sexually transmitted infections, both ulcerative and discharges, and having an annual incidence of HIV at 2.2%. That means 2 people out of 100 would acquire HIV every year in that community. And then there was a control group, so it was more like a demonstration case control environment. And it was found that the 2 communities which were provided the syndromic treatment, amongst them the one which was provided had 2.2%, the one which was not provided a treatment for STI had a higher, double the rate of HIV transmission. So again, it brought us back to intervening the STIs. But public health again goes a step beyond, and everybody said that, okay, why are we going to be waiting for STI patients coming for treatment? Best is to deliver a mass treatment of STI to the entire community without examining them and look for STI. And that's like create a sterile environment and get over with it. Maybe every 6 months do mass treatments. But that didn't work at all. So there was no significant impact of just loading up people with antibiotics. So that was kind of dumped after a while. So that was one of the modifications of the environment or the risk characteristics of the epidemic. And the other one that intervention started was voluntary counseling and testing. And what it found from multi-center studies was that for an individual knowing his or her HIV status, it reduced the risk-taking sexual behavior of individuals. If an individual went through a test and went through a pre-test counseling and the post-test counseling, that individual was, even if negative, would then modify his or her sexual behavior towards more healthy behavior in terms of having less number of sexual partners. And also, the individuals who went through VCTs were found to be having fewer future STIs, showing that they had changed a part of their sexual behavior. But having said this, one would be careful to say that behaviors are difficult to change. And within them, the health behaviors are difficult to change. And within that, the sexual behaviors are even more difficult to change. So if we assume that giving a certain level of knowledge to the communities will alter their sexual behavior, then I think we're probably applying a very simplistic characteristic change principle. It is too simplistic to be able to change sexual behaviors of people just by knowledge. So what will take it, we'll address it a little later. But there is a concept of co-transmitters that is now is the mainstay. There are either people who are co-transmitters, there are people who are non-core group transmitters. Then the question will arise is, where is the group of no transmitters? So we have people who are co-transmitters, there are people who are non-core transmitters, but there are no individuals who are non-transmitters. And that takes us to a fundamental study of sexual behaviors in several communities across the globe. And there are several studies that one can look back. Some are, of course, recent. A lot of them are recent 10 years, but some of them are 50 years old studies, especially in the West. And what most of them show, of course, with differences, is that predominantly in communities, 20% people have high-risk behavior in terms of their sexual behavior. 50% of people have moderate risk-taking behavior as far as sex is concerned. And the remaining 30% are low risk-taking people or low vulnerable people. So that makes 100%. So where would the people who are non-vulnerable, where are the people who are otherwise not vulnerable? So I think within the human behavior, we find that individuals are either low vulnerable, moderate vulnerable, or highly vulnerable to HIV and sexual diseases, because that is one of the basic instinct and a behavior of individuals. So within the core transmitters, these are the people who would be 10 times more sexually active than the non-core group. An example will be that a core transmitter would possibly have one new sexual partner every 5 days, versus the non-core transmitter will have one partner in 50 days. But that also is high. Somebody having one new sexual partner in 2 months, that is like talking of 6 sexual partners in a year, is a non-core transmitter, but is a definite possibility of a transmitter. So essentially we are talking of now a spectrum where you say that, okay, there are sex workers, there are clients of sex workers, there are drug users, there are migrant laborers, there are all these individuals who fall in that 20%, and then there are people who fall in that 50% category, and then there are people who fall in 30% category. But they have to fall in these categories. So if we move with our public health knowledge with this background, I think we have understood part of today's lecture, that the risk behaviors are universal and in all communities. This slide I showed you last time as well, but again trying to make sure that we understand that bringing synergies between interventions that are aimed at modifying the environment or the host or the agent, it brings you much more control of transmission. And what this slide essentially says is that we should be promoting condoms among individuals who are high-risk behaviors and moderate risk behaviors, and at the same time treat their sexually transmitted diseases if they do exist. So there is now, we say, is convergence of interventions or convergence of various strategies to modify the risk behavior as well as the environment. And one new thing that has happened of late in the last 10 years, I would say, is the antiretroviral treatment. Now, antiretroviral treatment is important for people who are infected, so you want to make sure that they do not get more diseases, that they do not have terrible type of diseases for the period of time that they have the terminal phase of HIV and AIDS. And you would want to see that they have better quality of life, more or less with these drugs now. Individuals who are adherent and compliant to the regimes can live their natural course of life, or the natural expectancy of life with these antiretroviral treatment. But for these expensive treatments to be dispensed and be made available to all those who need them, there have to be better public health explanations for instituting expensive therapeutics. And one important explanation that came up was, would antiretroviral treatment, apart from benefiting an individual, that's fine. Yes, it makes good clinical care sense. But from public health point of view is, does antiretroviral treatment also reduce the transmissibility of virus from these individuals if they continue to be high-risk individuals? And there are several studies that have reaffirmed the hypothesis that when an individual is on antiretroviral therapy, not only he benefits his own clinical status and his own quality of life, that individual reduces the probability of HIV transmission from him or her by 50 times. So, in other words, you are now also changing the characteristic of risk characteristic from an individual to the other individuals. And then there are several studies that have convinced the globe leaders, including the G20, that if you do not spend money to treat these individuals with antiretroviral treatment, that the first-line treatment costs $600 per person. Now, that is the best it has reached at this moment, $600 per person per year. But when these antiretroviral therapies started in 1993, that is about 15 years ago, the first line of antiretroviral treatment used to cost something closer to $20,000 per year for an individual. So no governments, including the US government, would be able to bear that kind of additional burden for fewer number of people benefiting out of these drugs. But over a period of time, the volumes and the generic kind of drugs available. So this is another change in the host has been created in a way that you use the therapeutics to benefit the individual. At the same time, the virus load in the individual declines 50 times, and so would be the probability of transmission from these individuals onwards. And then there are other ways to modify. Of course, sexual behaviors will take time to change, and they take decades to change in communities. So you want to look at what else can change around in terms of transmission. And what else seems to have would be changing is the status of male circumcision. We are talking about male circumcision. WHO does not support any form of female circumcision at any point. So we are talking about male circumcision that has been shown to reduce the risk of HIV transmission from a woman to man or man to woman, either way, by 50 to 70%. So in that case, this again as an intervention to modify the transmissibility of the virus. And then one last is, are we doing enough for women? Are we empowering women enough to be able to be the passive receivers of the STI as well as HIV? So there are now microbicides. Several have been tried. N9 is the one which has been very long used as a spermicide, as an anti-contraceptive, and as well as possible anti-HIV, but not very efficient. And now there's a new gel that has now gone through human trials and applied even 12 hours before the sexual intercourse can reduce the probability of transmission of HIV. So there are several movements that are happening on several tracks. We will now also address, apart from the kind of sexual behaviors that we talked about, whether they are between men and women or men and men and women, we also have special categories or special situations and which make people more vulnerable to risk-taking behaviors. And these are predominantly the migrant populations. Now, migrant populations obviously, or we call the displaced populations, they could be due to natural disasters. They are basically also sometimes made by man-made disasters where there are wars and political conflicts.